عليكم ورحمة الله وبركاته. كيف حالكم جميعا؟ I hope you all are doing fine. Today we will talk about salivary gland. I know that you already took this topic in different subjects, but today we will talk about salivary gland from the surgical point of view. طيب, briefly, we'll have a small introduction. What is the salivary gland? The salivary gland is an exocrine gland that produces saliva through the ducts. And what is the saliva? Saliva is an extracellular fluid produced and secreted by the salivary gland where? In the mouth. It is composed of mainly water. About 99% of the saliva composition is water, and variety of electrolytes such as bicarbonate, calcium, phosphate. And also it contains immunoglobulins, proteins, enzymes, mucin, and nitrogenous products such as urea and ammonia. The total production of the saliva per day is about 500 to 600 milliliter per day. The production includes both unstimulated and stimulated saliva. The unstimulated usually is about 300 milliliter per day, and the stimulated salivary production is about 200 milliliter per day. As we all know, the function of the saliva, it acts as a lubricant, and it's also important in the protection of the oral cavity. It has a buffering action. It maintains the tooth integrity. It also has an antibacterial, antifungal, antiviral effect, and it helps in the taste and digestion. Because we are talking about the salivary gland, you need to know that the salivary gland divides into major salivary glands and minor salivary glands. The major salivary glands include parotid gland, submandibular gland, and sublingual gland. The location of the parotid gland, it is on the lateral side of the face, anterior to the ear. The submandibular gland located at the angle of the mandible, and the sublingual gland, it's a V-shaped structure on the floor of the mouth. The duct of the parotid gland, it called Stenson's duct, and it open at the parotid papilla. The location of the parotid papilla, it's in the buccal mucosa between the maxillary first and second molar. Sometimes you can see the opening of Stenson's duct in the patients. The duct of the submandibular gland, it is the Wharton duct. It open in the floor of the mouth anteriorly. The sublingual glands, the duct open in the sublingual fold in the floor of the mouth with many ducts openings. The characteristic of the parotid gland. The secretion of the parotid gland, or the saliva secreted by the parotid gland, it is a serous secretion, and it contains 20% of unstimulated volume. The salivary secretion of the submandibular gland, it is mixed mucus and serous secretion. It composes 65% of unstimulated salivary volume and 30% of the stimulated one. The sublingual gland, it is the secretion, it's a mucus secretion, and it composes 7 to 8% of the unstimulated flow. In both pictures, you can see the parotid gland and the associated parotid duct, which moves forward to open in the buccal vestibule between the first and second molar. You also can see both the sublingual and submandibular gland with the ducts. The ducts, the Wharton duct of the submandibular, you can see it opens anteriorly in the floor of the mouth, and the sublingual ducts has a multiple opening. Sometimes when you apply pressure شوية أو massage in the floor of the mouth, you see secretion coming out from the opening of the ducts. The other type of the salivary glands are the minor salivary glands. They are multiple. There are about 800 to 1000 minor salivary glands. Their location, they're located in the anterior hard palate with the exception of the incisive papilla area. They're also present in the soft palate, buccal and labial mucosa and vestibule, floor of the mouth, dorsum of the tongue anterior to circumvallate papilla, ventral tongue, gingiva and attached alveolar mucosa. It consists 7 to 8% of unstimulated flow. The secretion is a mucus secretion. Here you can see the normal histological structures of the different type of the gland. As we said before, the parotid salivary gland is completely serous. The submandibular salivary gland is a mixed mucus and serous. The sublingual and the minor salivary glands are completely mucus. We finished the brief introduction. Now we will talk about the disorders of the salivary gland. Before we talk about the disorders of the salivary gland, we need to know about the diagnostic modalities, which are going to help you to diagnose the salivary gland disease. So first, you need to make a good history and clinical exam. Then we'll talk about some of the investigations, because I'm sure that you already talk about the functional studies in other subjects to measure the salivary flow, about the stimulated and unstimulated. We talked about the fine needle aspiration in last year in the biopsy lecture. We'll talk today about the imaging studies, cyanochemistry, and the endoscopic procedures. So patient with the salivary gland disorder may present with a complaint of pain. You should ask the patient how bad is the pain, where is the pain, because many other related structures may mimic the salivary gland pain. For example, teeth, temporomandibular joint, and external ear may cause pain. You need to ask the patient about what is the character. Is it sharp pain? Is it associated with the meal? Is it deep? Is it continuous? Because continuous pain may relate to malignant disease. Some patients present to you with the swelling or lump. You need to know if this is localized or generalized. How long has the swelling been there? Is it getting bigger? Because benign tumor usually grow very slowly. And you need to know if this is unilateral, bilateral. Sometimes Sjogren syndrome affect all 4 main salivary glands. You need to know if there is a facial nerve weakness, because this occurs usually with the malignancy. You need to know, does the eating make it worse? Because if this has happened, usually it is a stones or an obstruction. You need to know if the patient is taking any drugs, because some drugs may cause xerostomia or hyposalivation. Other drugs also can cause an enlargement of the gland. So you need to know all of these questions and ask your patient carefully to make a good history. After you took your history, you need to do a physical examination of the salivary gland, and it should be done in systematic fashion. The whole head and neck area should be inspected. You should look for any sign of asymmetry, discoloration, pus, presence of a sinus tract, and any unilateral or bilateral enlargement. After the inspection, you need to do palpation, both extraorally and intraorally. You also can evaluate the patency of the salivary duct, and it's detected by exerting a gentle pressure on the gland and observing the flow coming out from the orifice. You can observe the color, the texture, viscosity of the saliva. The radiograph, it is the most important investigation in the patient with the salivary gland problem. Next to the history and examination, it gives the most valuable information. We'll talk about the plain film radiograph, cyalography, CT scan, MRI, ultrasound, salivary scintigraphy. Plain film radiographs. You can use a mandibular occlusal film, and it is most useful for detecting the sublingual and submandibular gland stones in the anterior floor of the mouth. When it is in the posterior part of the submandibular duct, it is recommended to do a CT scan. Also, you can do a panoramic radiographs to see the stones in the parotid gland, or sometimes if it's posteriorly located in the submandibular area. The plain film radiographs gives high false negative for detecting radiolucent stones or mucus plugs, which appear radiolucent in the radiograph. Cyalography is the gold standard. Its indication for detection radiopaque or radiolucent stones or mucus plugs, the one that you cannot detect with the plain radiograph. It also shows the extent of the destruction of the salivary duct or gland, which happen as a result of an obstructive, inflammatory, traumatic, or neoplastic disease. Sometimes the cyalography used as a therapeutic maneuver because the duct system is dilated during the study. So when you insert the cyalography instruments, the duct will be dilated, and the small mucus plug or necrotic debris may be cleared by itself during the injection of the contrast medium into the ductal system. So in the cyalography, you need to inject the contrast medium. Okay? We'll talk more about it. How to do the cyalography? First, you need to do cannulation of the duct, to put something like a cannula inside the duct. Why? Because you need to inject a contrast media into the ductal system. After you inject the contrast media, you need to do a series of radiographic images at a various time. Approximately 0.5 to 1 milliliter of contrast material is injected. There are two types of the contrast media: water-soluble and oil-based solutions. Most of the clinicians prefer to use a water-soluble media. Why? Because it is less viscous, and when it is less viscous, it's more easily to be injected. It doesn't gonna cause pain for the patient when you inject it. Also, the dissemination into the finer portion of the ductal system is easier than for the rapid elimination from the gland. In the cyalography, you can request either conventional cyalogram, as you can see in the conventional cyalogram picture, or you can ask for CBCT or MRI, as you can see in the picture on the right. There are 3 different phases according to the time when you inject the contrast medium. So the first one is the ductal phase, when the contrast media is still in the duct. The second phase is the acinar phase, when the contrast media go to the gland itself. Then the evacuation phase, when the contrast media leaves the gland through the duct. There are 3 main contraindications to the cyalography. The first one, when you have an acute inflammation of the salivary gland. Why? Because everything will be leaky. So when you inject the contrast media, it will act as a foreign body because it will leak through the leaky duct and it will pour into the soft tissue. The second one, when the patient has a history of iodine sensitivity, because the contrast media will contain an iodine. The third contraindication is when a patient will go for a thyroid gland study, because the iodine in the salivary gland or the duct system will interfere with the interpretation of the thyroid gland scan. In this picture or the cyanogram of the left parotid gland, you see the characteristic of sausage-like appearance of the duct. This indicates that there is a ductal damage from an obstructive disease with irregular narrowing of the duct caused by reparative fibrosis. Another presentation of the cyalography as in the parotid cyalodinitis with the acinar destruction from the chronic disease. The diagram shows pruning like when you trim the tree caused by acinar destruction. Another form, as you can see here in the left parotid gland, the form looks like a ball in the hand phenomenon, as the arrow shows. This is the filling defect indicates that there is a tumor of the gland with a displacement of the normal surrounding ductal anatomy. So the tumor pushed the duct away from the tumor, so it gives the appearance of the ball in the hand. Another type of the radiograph is the ultrasonography. It is important in the differentiation between the malignant and the benign disease. In the salivary gland tumor, it is important to know information regarding the vascularization. So sometimes we use the color Doppler. Ultrasonography represents the most common examination method for a small nodular lesion of the parotid gland, and it's also helpful to guide in the biopsy for the diagnostic purpose. As you remember last year, sometimes we said we can use the color Doppler ultrasonography as a adjunct method for the biopsy. Scintigraphy is another type of the radiographic diagnostic method. It used the radioactive isotope, usually technetium-99. It's injected intravenously, which gets distributed throughout the body and is taken up by a variety of the tissue. So sometimes the tissues that have a high mitotic activity takes up most of the technetium. So it appear كده يعني لونه مميز في الأشعة. The major limitation of this study is the patient needs radiation exposure and it shows poor resolution of the image. You will see in the next picture الصورة مو مرة يبان فيها شيء بس في كده point هي اللي أخذت الراديو أكتيف ايزوتوب فتبان كده مشعة أو سوري أغمق شوية. Salivary gland scintigraphy may demonstrate increase the uptake of radioactive isotope in acute inflamed gland, or sometimes decrease the uptake في chronically inflamed gland and presence of mass lesion. طيب شايفين هذه الصورة؟ هذا salivary gland scintigraphy. البوينت اللي عليها الأروز اللي غامقة شوية or dark in color هذا demonstrate sometimes malignancy or a lesion with highly mitotic activity. فالماتيريال هذه لما after I inject it intravenously تروح لهذه الاريا. فلما أصور X-ray أو راديوغراف يطلع البيشنت عنده الدارك اريا هذه تبين لي إنه فيه مشكلة. أوكي وغالبا نستعمل فيها زي ما قلنا التكنيتشيوم 99. We finished about the different radiographic modality that help in the diagnosis. Now we'll talk about the endoscope. Salivary endoscope called cyaloendoscopy. And here you use a direct vision by using a small video camera with the light at the end with the flexible cannula. You introduce it into the ductal system. So the endoscope used to direct visualization the mucus plug and the stones in the lumen of the ductal system of the salivary gland. It also may be with a therapeutic maneuver because sometimes it dilates the small strictures and flush the small mucus plug on or stone. Sometimes small laser or lithotripsy device اللي هو جهاز يقوم بتفتيت الحصوات. فلما أدخله مع الاندوسكوب هيفتت الحصوة أو السيالوليث. بعدين لما أعمل irrigation with the fluid sometimes تطلع يعني spontaneous evacuation. In this picture you see the armamentarium for the endoscope, endoscopy. So you see the cannula attached to the camera. So when you go inside the canal شايفين B و C هذا الستون. بعدين الصورة دي اللي لحالها على اليمين. أحيانا البروب ولا الكانيولا هذه فيها شيء كده زي الباسكت عشان يدخل ويقدر يمسك الستون ويسحبها for retrieval. Okay. In this picture you see after you go inside the duct with the endoscopy, you either saw mucosal plug ولا stone or stenosis or strictures. يعني الduct صارت ضيقة شوية. Another diagnostic modalities is to do a cyanochemistry. يعني نحلل السلايفا to see if there is an elevated sodium concentration, decreased potassium concentration. This may indicate an inflammatory sialadenitis. Most recently, an area of the head and neck oncology في شيء اسمه salivary proteomics for molecular marker. يستعملوها عشان زي markers عشان يشوفوا detection of diagnosis of oral squamous cell carcinoma. يعني يحللوها ويشوفوا either for the minerals or for the biomarkers for the squamous cell carcinoma. We'll start talking about the salivary gland disorder, and we'll start by sialolith or salivary gland stones. The etiological factors: obstruction, reduced salivary flow rate, dehydration, changes in the salivary pH associated with the oropharyngeal sepsis. إيش يعني؟ يعني هذه الفاكتورز اللي تزيد من احتمالية حصول السيالوليث. obstruction يعني الدكت نفسها صارت ضيقة، فزي ما احنا عارفين السلايفا فيها minerals وأملاح، فلما تكون الدكت ضيقة والسليفري فلو نفس الفلو يكون أقل ويصير فيه dehydration، هذا حيؤدي إنه يحصل الحصوة. طيب بعدين في شيء اسمها retrograde theory of lithogenesis. في theory كده retrograde. إيش يعني؟ retrograde يعني تكونت الحصوة from a retrograde migration of food, bacteria or foreign body and debris from the oral cavity that enter the ductal system. retrograde يعني دخلت من الأورال cavity على الجلاند. أوكي، هي المفروض الجلاند إيش تسوي؟ المفروض الجلاند تطلع السلايفا من الجلاند للأورال cavity، بس retrograde يعني دخلت بالعكس. These small particles act as the needles that lead to stone formation. لما تدخل الفود ديبريز ولا أي ديبريز حتجمع حوالينها الأملاح other components عشان تسوي له الستونز. هذا البروسيس facilitated by sphincter action of the ductal orifices that act to maintain the debris in the ductal system. الأوريفيس فيها زي السفنكتر. sphincter is like a valve. يعني سهل لها إنها تدخل من الأورال كافيتي على الدكت بس ما تطلع عشان السفنكتر تكون مقفولة. Okay. In this picture you see a left submandibular edema caused by an obstruction from a submandibular sialolith. طيب كده نشرح شوية. إيش اللي سبب الإديمة؟ اللي سبب الإديمة الأوبستراكشن اللي جاي من السيالوليث. أوكي. فالسليفري جلاند الفانكشن حقها إن هي secrete السلايفا. once it secretes the saliva cannot go out to the oral cavity because of the obstruction by the sialolith. فتتجمع وتؤدي إلى هذا الانتفاخ. وأحيانا قلنا في الهيستوري إنه before eating أو لما مثلا قبل ما يأكل الشخص يزيد الانتفاخ ويزيد الألم. ليش؟ عشان as you remember in the physiology السلايفا كيف يعني مثلا قبل الأكل يزيد شوية الجسم يزيد من إفراز السلايفا، فقبل الأكل يزيد إفراز السلايفا cannot go to the oral cavity فتتجمع وتسوي هذه الإديمة is gonna exert pressure على التيشو around which gonna cause pain. okay. فعرفنا ليش يحس البيشنت pain or swelling قبل الأكل. As we said before, the cyanulith can be radiopaque or radiolucent. This depends on the calcium concentration and the degree of the stone maturation. There is a higher incidence of occurrence of the cyanulith in the submandibular gland. Those are the factors that make a higher incidence of the submandibular stone. Submandibular gland has a high calcium concentration in the saliva. The alkaline pH of the submandibular saliva composition. It also has several anatomical factors, which include that the Wharton duct is the longest duct. It has two sharp curves in its course, one at the posterior border of the mylohyoid, the other one is near the ductal opening in the anterior floor of the mouth. It also has a small punctum or small orifice and the rule of the gravity. The management of the submandibular gland stone, it depends on the duration of the symptoms, the number of repeated episodes, the size and the location of the stone. The management of the submandibular gland stones for the general dentist. You need first to know the classic sign and symptoms for the cyanulith. For general كده, not only for the submandibular gland. So you have to have pain and swelling of the submandibular gland exacerbated at the meal time. Also, you have to have a diminished salivary flow or pus from the Wharton duct. Tenderness of the submandibular gland, cervical lymphadenopathy, palpable stone in the anterior floor of the mouth or at the orifice of the Stenson duct. You also can do a mandibular occlusal radiograph or CBCT to see the stone in the Wharton duct. After you see the sign and symptoms and evaluate, we'll go to the treatment. There is two locations for the stone in the duct. It could be in anterior Wharton duct stone or in the posterior. If it's in the anterior, it means it's near to the floor of the mouth. So you have to attempt to dilate the Wharton duct with the lacrimal probe. Be careful not to displace the stone posteriorly. يعني if you apply شوية pressure, you get the probe, يعني معاك البروب. وتحاول شوية توسع الأورفيس. Sometimes instead of إنك توسع الأورفيس, you're gonna push the stone back. So be careful, don't to displace the stone posteriorly. ممكن نعمل مساج للgland with a bimanual palpation to express the stone out of the ductal orifice. If successful, prescribe salivary stimulants. إذا كان اللوكيشن حقها في posterior or you cannot visualize the stone, refer to oral maxillofacial surgeon حنشوف إيش حيسوي. طيب, as a revision, we said the submandibular stones can classified as an anterior or posterior. How do you know? So if there is a transverse line drawn across the mandibular arch between the mandibular first molars, هذا line هو حيقول لنا إذا the stone anterior له حتكون anterior وإذا stone posterior له حتكون posterior. Intraoral removal by two methods. زي ما قلنا widening ولا dilatation of the orifice, ولا ممكن إيش نسوي incision made in the floor. If the stone present in the posterior part, sometimes you need to do an extraoral approach for the removal of the gland. So the gland itself need to be removed. Of course with the stones. You also can do something called extracorporeal shock wave lithotripsy. قلنا lithotripsy تفتيت زي فتة الحصوة. It's a better alternative to cyaludenectomy for treatment of the cyanulithiasis. Consider the treatment of choice for all parotid stones and submandibular stones measuring less than 7 mm. Lithotripsy إيش هو physical destruction of the hardened mass like a kidney stone زي ما قلنا التفتيت. Here in the picture you see they put the gel, then they used the shock wave lithotripsy. هو يطلع كده waves عشان يفتت الحصوة. Those clinical pictures show the surgical approaches for removal cellulite. The first one is by using an endoscope. The second one is the transoral, it's inside the mouth. The third one is through transcutaneous or submandibular cyaludenectomy. We talked about the submandibular cellulite, now we'll talk about the parotid cellulite. The parotid gland is examined by inspection and palpation of the gland extraorally over the ascending mandibular ramus. As we said before, you need to do examination and by inspection and palpation. Then the Sensens duct and its orifice can be examined intraorally. If found in the distal third of the Sensens duct, may be removed after dilation of the duct orifice or may be require surgical exposure to gain access of the stone. فإذا كانت موجودة الستونز قريب من الأورفيس ممكن زي ما قلنا نوسع الأورفيس or you may need to do a surgical exposure. إذا كانت الستون في الجلاند نفسها an extraoral approach to remove a stone و sometimes a superficial lobe of the parotid gland and sometimes you need to remove a part of the gland or the whole gland. Sublingual cellulite, after you do an examination and the radiograph and you make sure where is the position, you do a simple excision of the stones and sometimes with the associated gland. This is the end of the first lecture of the salivary glands. I hope it wasn't difficult. If there is any question or if you still need more explanation or clarification, please approach me through email or via Telegram. Good luck.